Okay, so we are starting today the neuropathology board review, and that's why I call this an all-inclusive board review, because of these 60 slides that I'm going to preview, there would be no single question. I'm sure most likely there will not be any single question outside these 60 slides, and you'll be able to cover the high yield facts that you need to know for the boards for the neuropath. And as everyone know, neuropathology is not so extensive in the AP boards because it has its own subspecialty boards, but neuropath still constitutes a bunch of questions in your AP boards, so you need to cover these key facts, at least the most commons, so that you will be good and able to cover all the questions and score in get them all right. This will put you in a good situation when it comes to other specialties where the questions get a little bit more tricky, like cytology and like GYN. They ask the in-depth, but in neuropath, I feel like they always go with the broad ideas and they don't go into the details. So it's your chance, you have to grab it. So let's get started. And I always, for my neuropath board review, I go with the patterns. So what kind of patterns you might end up facing and what kind of images or pictures you might see in the questions. So the first thing we will go over the non-neoplastic part. I understand that most of the questions come in the brain tumors and in the neoplastic, but you have to know that there is also non-neoplastic component of neuropath, which includes some autopsy images or autopsy gross images, which might belong to your forensic part, but it's still neuropath. And there's also some infections that you need to cover. So let's start with the non-neoplastic part. So the first pattern is when you see vessels. So you see blood vessels, as you see right here. See this picture. So for this picture, as you see, all these lumens are actually blood vessels. And you can tell that this tissue, well, this is brain tissue. They will tell you that this is a brain, this is like a biopsy or biopsy from the brain. So it's fine. So you know that there is brain tissue here. But this is too much of vessels for the brain. It's a lot of vessels that you see here. And the vessels look very large. They look very dilated. And that's why we say that they are dilated, crowded vessels. When you see dilated, crowded vessels, so you are dealing with a vascular lesion. This vascular lesion is usually either an AV malformation, which is arteriovenous malformation. It's highly associated with some syndromes, and it might be hemangioblastoma. So how can I differentiate both? So you need to give a careful look to the brain tissue in between the vessels. So look at the brain tissue in between. So do you see any crowding of cells in the brain tissue here, Dina? Do you see any crowding of cells, any like abnormal cells which stand out really clear in this brain tissue in between the vessels?
No.
Yes, no, there is no crowding, there is no abnormal cells staring at me in this brain tissue. So the brain tissue in between the dilated vessels is normal. So this means that I'm dealing with an AVM or an AV malformation. So in AV malformation, it shows thick-walled arteries, as you see right there, dilated veins and dilated vessels with the intervening brain tissue looking normal. It has some degree of gliosis or fibrosis, but it doesn't have any abnormal like standing out cells in the brain tissue in between. You have to remember and memorize that AV malformation is highly associated with Sturge-Weber syndrome, which is a congenital or a hereditary syndrome. I know you guys know about it from the USMLE. It's one of the neurocutaneous disorders. If you remember, it's one of the neurocutaneous disorders. But this is highly associated with these AV malformations, and that's why these people who have Sturge-Weber syndromes, they might end up having some intractable seizures and some epilepsy. Also, they might end up having some intracranial hemorrhage. Here, I believe there is some hemorrhage right there. in between in this brain tissue. Yeah, GNAC. Yeah. But look at this. So see that. How Dina? How this differ from this? See the brain tissue in between. What do you see here in the brain?
There are multiple cells that they have like very large nuclei, hyperchromatic.
Yeah, exactly. See, they are staring at you. These cells look really abnormal. Oh my goodness. So see, but I still see the whole bunch of vessels here, the dilated vessels and the blood vessels all over. This is too much of the vessels, but the brain tissue in between shows abnormal cells. This means that we are in the middle of a lesion. We are in the middle of a neoplasm or a tumor. So this is hemangioblastoma. So see, hemangioblastoma, which is actually a WHO grade 1 tumor, it's not very aggressive. It shows vessels, but the vessels here are surrounded by neoplastic stroma. You have neoplastic stroma, neoplastic brain tissue. This one is also associated with a syndrome that you need to memorize, which is von Hippel-Lindau syndrome, which is a mutation in VHL gene on chromosome number 3. What other tumor is associated with von Hippel-Lindau? What other tumor is associated with von Hippel-Lindau?
RCC.
Yeah, welcome back, Mohammed. How are you? How's everything?
Good.
Sorry, I'm still living in New York. I didn't notice that there is time difference. I still don't accept the fact that I moved to Texas,
Well, welcome to Texas, and first and foremost, congratulations on passing your boards. And I'm happy you're now Central Time like me, so I'm happy with the timing, honestly.
Oh, really? So now we are in the same time zone? All right.
Yes.
So also, Dina said the same thing. Dina now is in the same time zone as mine. All right, so we're good. So this one is associated with VHL, and as Mohammed said, it's also associated with RCC. If you guys remember from our GU lectures, the von Hippel-Lindau is associated with RCC. So this, you see hemangioblastoma. What's the difference between hemangioblastoma and AV malformation? The brain tissue in between. The brain tissue in between here doesn't have any abnormal, scary looking cells, but here you see vessels, but the brain tissue in between is so scary. It has some kind of neoplastic stroma in between the vessels. That's hemangioblastoma. It's WHO grade 1, so low grade tumor. That's it. These are the two brain lesions that I need you to know where you will see vessels, a lot of vessels. So I see vessels. That's our first category. Next category in the non-neoplastic is infections. You need to know a whole bunch of CNS infections. And these infections kind of repeat itself in other organs, like the fungal infections you'll see here and you'll see in other organs. Let's look at this. Let's ask Dina again. What do you think? Well, this is brain. Why this is brain? Because they will tell you that this is brain. So what's your impression about these nuclei? What do you think about it?
I think it looks like the CMV because I see this inclusion, the intranuclear.
Good job. So you see like the nucleomegaly with viral inclusions inside. But here you are suspecting CMV. Well, totally fine, because CMV also lead to nucleomegaly and some kind of intranuclear inclusions. But here, if you look at the background, what do you see in the background? Do you see these cavitations or like these cystic spaces or just like cavities? See how the background is like degenerated. Can you see that? Can you see this in the background?
Yes.
Yeah, this is kind of neurodegeneration happening in the brain parenchyma in the background, and this is a kind of demyelination injury. So when you see the background is so like degenerative, and you see nucleomegaly with viral inclusions staring at you, and they will usually tell you that this patient is on chemotherapy or on immunosuppressant drugs. So you are dealing with JC virus. Please remember this, because JC virus is a virus that infects the oligodendroglea, which are responsible for the myelination of the neurons, and it leads to a kind of demyelination injury. And that's what you can appreciate in the background right here. There is like a kind of demyelination of the CNS parenchyma, and you see nucleomegaly with viral inclusions there which are due to the JC virus infection. So progressive multifocal leukoencephalopathy, this is what you see right here. It's due to infection by JC virus. It's highly associated with those who are immunosuppressed, such as like those who are having AIDS or those who are having some hematological malignancy, taking chemotherapy, taking immunosuppressive drugs. The histology would show oligodendrocytes. These are actually oligodendrocytes with nuclear inclusions and some enlarged astrocytes with focal demyelination. You'll see demyelination in the background. So immunosuppressed patients with viral inclusions, nucleomegaly, which look kind of like CMV, but you see demyelination in the background, that's JC virus or PML, okay? Here we go. That's the demyelination and that's the nucleomegaly and the viral inclusions. There we go. This is a very famous picture, and I'm sure most of you guys would recognize that. If Muhammad, what do you see here? This circular fungus? Nope, not chicken wire. This circular fungus with capsule. See the fungus with a capsule here. A lot of circles with thick capsule. What this fungus? Do you know it?
Crypto?
Yeah, that's Cryptococcus neoformans. So this is cryptococcal meningoencephalitis. And so it might infect also the brain parenchyma. When you see these circles with thick wall, I always say like it's like a circle, but you have like the wall of the circle is very thick. That's because this fungus is capsulated fungus, and the capsule sometimes stains with two main stains, the musicarmine stain and the India ink. Both of them, and GMS also stain this fungus, but stains the capsule. You will see that the capsule is very dark and the fungus is kind of lighter in color than the capsule. You see the fungus filling out all the slide, all the areas full of fungus or full of fungi. It's even there in the meninges and also in the brain tissue. That's what we call cryptococcal meningoencephalitis. So cryptococcal meningitis, here we have the mucin stain or the musicarmine stain. The polysaccharide coat of the cryptococcal yeast reacts strongly with mucin stain, and that's what you see right here. So this is actually the fungus in the brain tissue, and it's causing a lot of degeneration, as you see in the background, and a lot of necrosis. This is very bad. And it happened also in the immunosuppressed patients, such as the AIDS patients. What about this one? This is very tricky, but make sure you know it. I saw it in only one Q bank, but I don't believe it's that much high yield. But let's look at this image together. So this is a brain tissue. The background is brain tissue. You have some astrocytes, some neurons in between. So that's how the brain tissue is. It's just like glia with some neurons and some interspersed glial cells like astrocytes and these things. But you see, these are blood vessels, actually. The quality of the picture is not the best, actually, but these are vessels. These are blood vessels. And inside the vessels, you see RBCs in the vessels, and there is some small blue dots inside the RBCs. So can you see that? Can you appreciate these blue dots inside the RBCs? So here the RBCs inside the vessels, and you see some blue dots there inside the RBCs. That means that you are dealing with a blood infection or a blood parasite. What kind of blood parasites you might see in the brain? Anybody know? Which blood parasite might be malignant enough to reach the brain, and it usually reaches the brain, and it reaches the kidney and leads to multi-organ failure. That's malignant malaria. So please remember this. Blue dots inside the RBCs, in the blood vessels, in the brain tissue, that's malaria. That's cerebral malaria. It's a kind of malignant malaria, intraerythrocytic inclusions. They are suggestive of malaria. So the type of malaria which reached the brain is which type of plasmodium? Anybody know? You guys should be CP now, so you guys should know this from the microbiology. Which kind of malaria reached the brain? Which type of plasmodium? So I'll give you some choices. You have Plasmodium vivax, Plasmodium malariae, Plasmodium falciparum. Which one?
Is it falciparum?
Yeah, it is falciparum. It's falciparum. The falciparum is the one that leads to malignant malaria, and it might disseminate to a whole bunch of organs, might reach the brain, might reach the kidney, might reach everywhere, and it might lead to multi-organ failure. And so it's very bad, unfortunately. So that's how it looks in the picture in the brain. It was only in one question in path primer, and path primers sometimes go out of the box, so just in case. What about this? This is a very, very, very important and famous picture. Well, what you see here is a high power of a neuron. Okay, that's a neuron. How can we know that this is a neuron? You see that the chromatin is very light to the point that you see the nucleolus and the cell is so big. That's a neuron. So that's a high power of a neuron. What do you see here in the neuron? Can you see these red spots in the cytoplasm? Can you see these red spots in the cytoplasm? What are these? They are also in the nucleus, by the way. There is also some nuclear inclusions here. So this means that we're dealing with a virus, maybe. But what type of what kind of virus this is, which lead to these red spots or red inclusions? No, impossible. It cannot be herpes, because herpes will lead to margination and this kind of molding and this kind of herpes changes. But here, when you see red spots, intracytoplasmic and intranuclear in the neurons, that's Negri bodies. Please remember this. Very, very, very important. It's very important, very high yield. I saw it in a lot of QVACs, a whole bunch of QVACs. So it's Negri bodies, and this happened in rabies virus. Well, let's memorize. There is also some here. Can you see here? Can you see it here? See that? That's another also neuron with a lot of red spots in the cytoplasm and in the nucleus of the neuron. These are Negri bodies. So rabies virus, as everyone knows, this is a virus which is transmitted by, in the United States, is not by rabid animals or rabid dogs. It's usually by raccoons and also by the bats in the caves. In those who do cave exploration, they believe that the bats don't bite, but for some reason people spend the night in a cave with the bats and they go outside and they have rabies. You never know what's the mode of transmission, but for raccoon it's the bite of the raccoon. So raccoons, bats, that's in United States, but in immigrants, for the immigrants coming from other countries, it's usually stray dogs. Stray dogs, some of them contact rabies, and they start like being so aggressive and they start biting people, and this is when you get rabies. The rabies reach the CNS from the site of the bite by retrograde axonal transport. It goes with the axons and move along with the axons till it reaches the CNS. It usually infects what's the most common area in the brain which gets affected by the rabies? Basal ganglia? Nope. Hippocampus. Yeah, exactly. The most common area which get infected is usually the hippocampus. The hippocampus is the most common and earliest site of degeneration, in which these Negri bodies starts to appear inside the neurons, and this leads to neurodegeneration, and this is what leads to the rabies manifestations, like the hydrophobia and these kind of things. Okay, so Negri bodies, very important. You need to identify them. Intraneuronal red bodies in the cytoplasm and in the nucleus of the neurons. The two types of fungi, another two types of fungi with budding. This is not only important in neuro, actually. This is important everywhere. You need to know which fungus show this broad-based budding and which fungus, I wished I could test you guys. So which fungus show this broad-based budding and which fungus show this narrow-based budding? Anybody know? The one with broad-based budding, B is a B. Broad-based budding, the bud is with a very broad base, that's blastomycetes. So blastomycetes is broad-based budding. And the one with narrow base budding that you see a narrow base here is very, very constricted base for the budding. That's what we call histoplasmosis or histoplasma capsulatum. So histoplasmosis is a narrow base budding and blastomycetes is a broad base budding. Both of them might reach the CNS. They might reach the meninges, causing some meningitis, especially in those who are immunocompromised. So we have the Cryptococcus, which has the capsule, and we have the two fungi with budding. Broad-based budding is blastomycetes and narrow-based budding is histoplasma. And finally, this picture is very important. We always say this is the tachyzoids. I always say sacs of tachyzoids. So here you see a brain tissue and you see how much degenerated the brain tissue is. See the degeneration in the background, these like cystic appearances or just these empty spaces. This means that the tissue is degenerating. There's degenerating background and you see a lot of cells which are like, well, these could be glial cells or neurons, who knows? So these are a mix of glial cells and neurons with background degeneration. And then I see a lot of sacs, huge sacs. These sacs are full of some kind of an organism inside, which are the tachyzoids. So which organism show these sacs and aggregates of tachyzoids in the CNS and leads to significant CNS degeneration and encephalitis in immunocompromised patients? The toxo. Remember, toxoplasmosis. Toxoplasmosis. So remember, toxoplasmosis are sacs of tachyzoids with background CNS degeneration, and it's usually also immunocompromised patient. So let's go ahead and memorize everything. So let's go over the infections again. So here we see viral inclusions, looks like cytomegalovirus with the background degeneration and demyelination in an immunocompromised patient. That's JC virus. Okay, that's JC virus. Let's remove all the stuff and just go back again. Yeah. And then the next one is the circles with sick capsule, which stains with the mucin stain. That's the Cryptococcus, so it's cryptococcal meningitis. And then you see vessels with RBCs and then intraerythrocytic inclusions, like small blue dots inside the erythrocytes and inside the RBCs in the vessels. That's the malaria. It's malignant malaria, and usually it's Plasmodium falciparum. And then you see this red dots inside the cytoplasm and in the nucleus of the neurons. That's Negri bodies for rabies. And then you see the two other fungi, the broad-based budding, BBB with the B, blastomycetes. And then you have the narrow-based budding, that's for the histoplasma capsulatum. And then we have this sacs of tachyzoids, in the with a background brain degeneration. That's toxoplasmosis or toxoplasm. All right, everyone is okay. Any questions until now so far? So we have the non-neoplastic lesions, we took the vessels and we took the infections. Now you see these huge red balls. I always say, see huge red balls. What are these huge red balls? Anybody know? They usually exist in the
It looks very concentric, like samoma bodies.
It looks like samoma bodies, yeah. It's kind of sammomatous, but it's not samoma bodies. So what kind of bodies have it's red in color and it looks like samoma bodies, and it's circular and it usually exists inside the neuron. See, this is a neuron. How do you know this is a neuron? As I told you, large nucleus. The chromatin is very light to the point that you see the nucleolus there, and there is a huge bunch of cytoplasm. But here the cytoplasm has a lot of these circular bodies inside the neurons. And also it's there here. I think this is one of the substantia nigra neurons because we have melanin pigment here. So what do you think, guys? What kind of bodies are these? It's not Negri bodies, of course, because Negri bodies is very small. These are like huge red balls. These are Lewy bodies. Please remember this. Lewy bodies. Lewy bodies is the sign of Parkinson disease, and that's why you see the substantia nigra here, right? These are the neurons of the substantia nigra, in which they degenerate because of aggregation of Lewy bodies, which is a misfolded protein aggregate. The protein is called the alpha-synuclein. That's the misfolded protein, which start to accumulate inside the neurons of the substantia nigra, and they start to degenerate. When there's degeneration in the substantia nigra, you end up having low dopamine, and this is when you start to suffer from Parkinsonism. And the Parkinsonism is usually associated with the aggregates of Lewy bodies inside the neurons of the CNS in general, and this leads to a type of Lewy body dementia, right? There is a type of dementia called Lewy body dementia, which is highly associated with patients of Parkinson disease. So see, Lewy bodies are found in Parkinson disease and Lewy body dementia. They are eosinophilic, red, spherical, huge inclusions inside the neurons, and they are formed usually of alpha-synuclein. Very important, very high yield picture that you need to clearly identify. These are Lewy bodies. It have a special stain. Yeah, you can stain for alpha-synuclein. You can stain for alpha-synuclein and it lights up. Yeah. What if you see aggregates of neutrophils? Like here, it's like a dust. I always say it looks like dust. So see these multi-lobe nuclei, these are neutrophils. When you see aggregates of neutrophils, what could it be if this is brain tissue? If this is a high power of brain tissue and you see an area with an aggregates of neutrophils, what do you think? What do you think the diagnosis? Yes, of course, as Noor said, this could be an abscess. Yeah, it is. That's a brain abscess. That's a CNS abscess or brain abscess, and it usually manifests as a ring enhancing lesion on imaging. This is when what you have on imaging. You have like a ring like this with enhancement by contrast, because there is always this area of necrosis, which is the abscess, and usually the abscess is surrounded by congestion, an area of congestion, congested vessels. So the congested vessels lights up with the contrast, and this leads to a ring enhancement around the abscess in the CNS. So it usually leads to this ring enhancing lesions. When you take a biopsy or you send a frozen from this, it looks like dust of neutrophils inside the brain parenchyma. So see, you see necrotic debris, there is background necrosis, and there is abundant PMNs or polymorphonuclear leukocytes, PMNs. That's the only lesion with neutrophils that you might find in the CNS. Now, we are still in the non-neoplastic, but now we will go over gross specimens. Gross specimens is very famous. You will get like a couple of questions, maybe 1 or 2 questions on gross specimens from the CNS, and it's usually part of your forensic session or part of your forensic questions, because most of them is like intracranial hemorrhage, counter-coup injuries, these kind of autopsy findings. Let's start with the first ones. Oh, okay. What are these? Any guess? Dina, Muhammad?
It looks like hemorrhage.
Yes, it's hemorrhage. It's hemorrhage. But these are 2 flavors of intracranial hemorrhage. So see, what's this shiny background? What's this shiny background layer?
It looks like dura.
Yeah, that's dura. That's dura matter. So that's dura. So we see the hemorrhage above the dura here. So if the hemorrhage is above the dura, so this means that you're dealing with
Epidural.
yeah, epidural or extradural hemorrhage. So that's an extradural hematoma. The extradural hematoma is usually localized, as you see here. It's just limited to an area in the skull. And you know why? Because the dura is usually attached at the suture lines of the skull. So when there is bleeding in the epidural space, the bleeding is just confined by the areas of attachment of the dura to the skull sutures. And this is when you have this localized hematoma, which looks usually like a a biconvex or some biconcave, what they call it, I don't remember. They call it lens-like. I remember this. They call it like a lens. So that's the extradural hematoma, and it usually happened due to trauma of the middle meningeal artery, which is MMA. And it leads to the classic presentation, as we all know from our neuro lectures in the USMLE or in the boards. In the USMLE exams, you know that it leads at first to loss of consciousness due to the trauma, due to concussion. When you get hit, you lose consciousness because of the concussion, and then you regain consciousness. Once you regain consciousness, the bleeding starts from the middle meningeal artery, and it leads to the collection of blood, forming the hematoma, which press on the brain and causes herniation of the brain tissue. And this what leads to another loss of consciousness due to compression. So there is loss of consciousness due to concussion, and then you regain consciousness. This is what we call the lucid interval, in which you're fully conscious, you're fully alert, you look like apparently normal. That's the lucid interval, and then you lose consciousness again, but due to compression from the accumulation of blood pressing on the brain and brain herniation. Severe and might be fatal. That's the extradural hematoma. What's the other type? So see here it's like Muhammad. Here it's like we removed the dura, right? You don't see any dura in place, but you still see like a very huge spit of blood, which is widely dispersed on top of the brain. What do you think this would be?
Is that below the brain or on top of the brain?
It's on top of the brain.
Oh,
That's subdural. Yeah, that's subdural. Yeah, because this is diffuse. So see, when you see it's diffuse, it's not localized, and you don't see any dura in place. You don't see any dura in the area. That's the subdural hematoma, and this is usually due to injury of the bridging veins. The bridging veins are the veins which connect the dural venous sinuses to the extracranial veins and these kind of things. That's the bridging veins. The bridging veins are very small and fragile veins. So with any trauma to the brain, any like severe brain trauma, any accident, anything, they might rupture. And when they rupture, they spill blood in the subdural space. Here, the space is under the dura. So here, the hemorrhage is not confined by the areas of dural attachment to the skull. So here, the hemorrhage will be widely spread and diffuse, as you see right here. It stretches itself along the brain surface, and it's usually not localized. And that's why the loss of consciousness here would not be so rapid. The loss of consciousness here might take a little time to develop, because the bleeding is happening in a large and huge surface area, right? That's the subdural hematoma, and it happens due to lesion of the bridging veins. Well, what about this one? What about this one? What do you see here? What is this? What's this, Dean?
Circle of Willis?
Yeah, circle of Willis. I know how much you love this, and I know how much everyone loved the circle of Willis. I know it's the opposite. You don't love it anyway. But it's like the basilar and the two posterior cerebral arteries and this kind of stuff. These are like the circle of Willis. And then you see a spill of blood at the circle of Willis. So see, when you see a blood spill and you have the circle of Willis in the background, this means that the hemorrhage here is coming from one of the vessels of the circle of Willis. And the vessels of the circle of Willis, which give the blood supply to the brain, they exist in the subarachnoid space, right? So this means that you're dealing with a subarachnoid hemorrhage. Subarachnoid hemorrhage is an arterial hemorrhage because it happens due to rupture of one of the arteries of the circle of Willis. The rupture of the artery usually happens due to either hypertension or a defect in the arterial wall. It's either high pressure in the lumen or a defect in the wall. What kind of defects that might happen in the wall of the vessels of the circle of Willis? What do you think?
Aneurysms.
Yes, exactly, aneurysms. The whole bunch of flavors of aneurysm: mycotic aneurysm, congenital aneurysm, the perianeurysm, and the AV malformations. All these vessel abnormalities or vascular abnormalities might predispose to subarachnoid hemorrhage due to rupture of one of these vessels of the circle of Willis. So as you see here, this one appeared first, but this is subarachnoid hemorrhage, and it's usually due to aneurysm. I think the aneurysm is here. I still see it or can appreciate it, but it's fine. That's subarachnoid hemorrhage. Severe headache, as you remember, it's severe headache, rapidly progress to loss of consciousness, very fatal if left untreated. That's very important. That's the subarachnoid hemorrhage. On the other side here, what you see is these small areas of necrosis. See this small hole? Another one here. It's like I always say, it's like moth-eaten brain. It's like something that ate a piece of the brain. A piece of the brain is just getting engulfed or eaten by something. See that? See these are called lacunar infarct. Lacunar infarct. It's like a lacunae, a cavity in the brain substance or in the brain tissue. That's lacunar infarct. Lacunar infarct usually seen in hypertensive patients, and this is usually due to the effect of the hypertension on the small blood vessels supplying the brain tissue. It's due to arteriosclerosis and arteriolar affection by the hypertension. It leads to small areas of infarct in the brain. They call it lacunar infarct. So it's small perivascular infarcts seen in hypertension patients, and they are usually located inside the brain substance. When you take a section of the brain like this, you take a section like this, and you see here is the third ventricle, here are the lateral ventricles, and this tissue here is the basal ganglia. That's the basal ganglia, including the caudate, butamen, internal capsule. So it's usually located in this area. It's located in the basal ganglia, the thalamus, the area surrounding the third ventricle. Okay, that's the lacunar infarct. So make sure you identify lacunar infarct. This is very important. Look at this. Well, this looks to me like a hemorrhage as well, right? This looks like a hemorrhage here. And this also looks like a lot of areas of injury and hemorrhage. These are traumatic brain injuries. Traumatic brain injuries. This happened either in a big fight in which he got a very huge trauma to his brain, and he got kicked by someone, and then he flied in the air and landed on his head or something. This is what they call counter coup injuries. You know what counter coup injury is? Counter coup means an injury that happened due to sudden acceleration, deceleration. When there is a sudden and rapid acceleration, deceleration injury, there is a kind of the brain wobble inside the skull. It wobbles inside the skull, so it usually get hit in the opposite direction of the direction of trauma. It hits the skull very hard to the point that you see this kind of localized hemorrhage and degeneration in one side of the brain. So one side of the brain has hemorrhage and hematomas and this stuff. This is what? This is the front or the back. I think here this is the front. So if that's the front of the brain, so this means that the trauma came from the back. So this means that this guy might have fallen backwards. So he might have fallen backwards, and that's why he had the hemorrhage in the front. So I believe, yeah, see, it's a counter coup injury due to a fall backwards. That's frontal lobe hemorrhage in the frontal lobe. So how do we know that this is the front and this is the back? Because you see the brain stem here, and you see so you see the brain stem, and this is the back of the brain. So this is definitely the front. So it's frontal lobe hemorrhage, frontal lobe lesion, which usually happen in the counter coup injury. This one also is multiple contusions. You see these contusion, 1, 2, here's 3, here's 4, 5, 6, 7. So these are multiple contusions, and this is usually due to a fall. This is multiple punctate hemorrhage that you need to identify. You might end up having these gross brain images in your exam, so you need to clearly identify these kind of abnormalities. What do you see here? What's this area? Which area this is? Anybody can tell me?
Bones?
That's the pons. Yeah, that's the pons. I see Hamid here. Welcome. Welcome. Nice to meet you.
Thank you. Nice to meet you too. Sorry, my name is Hamida.
Hamida, not
Yes,
Okay.
yes.
And are you in residency or not yet?
Residency 4th year.
4th year resident. Oh wow. So you are going for your boards this year?
Yes.
Oh, okay. Good luck with that. So
Thank
She's
you
my
so much.
co-resident. She's my
she-
co-resident. I added her. Yeah.
so she's your co-resident. All right. Good.
She's my senior. My senior.
Yeah,
Okay, good. So,
of course.
I had Mohammed for a long time, and now it's nice to have you here. So
Thank you.
yeah, so keep yourself posted on the Telegram. I always like confirm that we have a meeting, but today, sorry, I miscalculated because I just moved to Texas, so I still feel like I'm in New York, so I
I
didn't.
see.
It's okay.
Thank you for having me. Thank you.
Yeah, sure, absolutely, my pleasure. So we have here pons. So you see the pons here. So these are the different types of abnormalities or gross abnormalities that you might see in the pons in your exam. So first one is here. You see this central degeneration in the pons. Can you see it here? So this central area looks really degenerated. These are the pontine fibers, by the way. Pontine fibers are the fibers of the corticospinal tract going down in the pons. So these are pontine fibers. This is normal, but see this central area of degeneration. This is called central pontine degeneration, or they call it central pontine myelinolysis. This is usually due to rapid correction of hyponatremia, as you mentioned, Noor, good job. This is usually due to rapid correction of electrolyte imbalance or rapid correction of hyponatremia. When you correct the hyponatremia so rapid and the tonicity goes up real quick, this leads to demyelination injury in the center of the pons. And this is what we call the central pontine myelinolysis. This is due to rapid correction of hyponatremia. Very important, and you need to clearly identify this gross finding. The other one, what do you see here? Well, what do you think here? Well, I see a lot of hemorrhage. I see diffuse areas of hemorrhage. Can anybody tell me what type of hemorrhage this is? What kind of hemorrhage is famous to happen in the pons? It has like a kind of a French name, I think. Anybody remember this? It's called Duret. Yeah.
Bouchard something.
No, it's called Duret hemorrhage. It's called Duret hemorrhage. Duret hemorrhage is a kind of hemorrhage that happen in the pons, and it happens with herniation. When the brain herniates down, this leads to downward displacement of the pons. And as you know, the pons is supplied by some perforating arteries, which are coming usually from the basilar. So we have the pons here, and the basilar artery is going up from the vertebral, and it gives kind of perforating branches or perforating vessels, which are small, delicate vessels that enter the pons and give the blood supply. So when the pons is rapidly displaced downwards, this might tear off these small vessels and lead to some kind of intraparenchymal pontine hemorrhage. This intraparenchymal pontine hemorrhage is called Duret hemorrhage, and it might lead to very, very bad deformity. It might lead to what they call locked-in syndrome. Anybody heard about this locked-in syndrome? Locked-in syndrome happens due to degeneration of the pons, which lead to affection of the pontine reticular formation. The pontine reticular formation. With the affection of the pontine reticular formation, you end up having this kind of locked-in syndrome in which the patient his eyes are open and he follows people with his eyes, and his eyes shut down when he sleeps, but he never give any response or any reaction. He can't even talk or move his head. That's what we call the locked-in syndrome. Oh my God, Noor remembers all my all my mnemonics from the USMLE. But I used to give like mnemonics, which is Egyptian mnemonics, Arabic mnemonics, so it doesn't work here, unfortunately. So, all right, so this is Duret hemorrhage. The Duret hemorrhage is due to downward compression or downward herniation, and this leads to stretching and ischemia of the perforating vessels or perforating arteries which supply the pons, and this leads to pontine intraparenchymal hemorrhage, as you see right there. So see this area of eaten or moth-eaten pons? It's the same thing. That's also lacunar infarct. That's also a lacunar infarct. So I'm just letting you know that lacunar infarct might happen also in the brainstem, and it might happen in the pons. The same thing, lacunar infarcts are due to hypertension and the affection of the small vessels by the high blood pressure. Okay? All right. So moving forward, here's the third ventricle. Okay, that's the third ventricle. So on both sides of the third ventricle are the basal ganglia, or you might say that these are the caudate / putamen / internal capsule, blah blah blah. But what are these two things hanging down below the third ventricle here? Anybody know?
Memory bodies?
What mammillary bodies?
Mammillary bodies, yeah.
Yeah, these are mammillary bodies. These are the two mammillary bodies. What do you see here in these mammillary bodies, Dina?
It's very dark spots, maybe hemorrhage.
Yeah, maybe hemorrhage or degeneration. That's degeneration in the mammillary bodies. What kind of syndrome there would be degeneration in the mammillary bodies? Do you remember? It was highly associated with alcoholism. You remember when people drink alcohol? This leads to thiamine deficiency. Do you remember the thiamine deficiency, which is vitamin B1 deficiency? This thiamine deficiency leads to decrease in TPP, which is the thiamine pyrophosphate. The thiamine pyrophosphate is an important coenzyme for the reactions of the Krebs cycle. So this leads to stop of Krebs cycle and leads to significant decrease in energy production, and this leads to brain degeneration, which starts usually in these mammillary bodies that you see right there. What does this call? This is called Wernicke-Korsakoff syndrome. This is called Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome, there is degeneration in the mammillary bodies, and this leads to ataxia. The patient kind of like is ataxic, shows some ataxia, and he shows a classic confabulations. What kind of confabulations? The confabulation means that there is kind of memory gaps, and for some reason, this patient start filling these memory gaps by things that never happen. He's just faking up events that happen, but it never happened. This is what we call confabulations. So like I remember that I woke up in the morning, but I don't remember that I gave lectures. I remember that in the afternoon I met my friend, but I don't remember that we went out together and we went to a restaurant. But then I start telling you that I woke up, and then I start telling something else other than giving lectures. Like I walked outside or just went somewhere, blah, blah, blah. And then I met my friend, and then I forgot that we went to a restaurant. I would say we went to the cinema or went to somewhere else. So it's a kind of a confabulation, memory gaps, which are filled by events that never happened. That's one of the classic features of Korsakoff dementia or Korsakoff amnesia. They call it Korsakoff amnesia. So here's Wernicke encephalopathy. It's mammillary bodies degeneration due to thiamine deficiency. Very important. It's highly, highly associated with alcohol or alcoholism. Okay, what about the other side? The other side, see, when you look here at these ventricles are getting very huge. Oh my goodness. It's very huge ventricles. The ventricles are getting so big. Is this hydrocephalus? Well, could be. It could be a hydrocephalus, and it could be atrophy. So it could be hydrocephalus, and it could be atrophy of the brain surrounding these ventricles, leading to pseudodilatation of the ventricles. What's more likely here? What do you think? Is this atrophy or is this hydrocephalus? What do you think? That's atrophy. Okay, why? Anybody have any idea?
This is normal
Silka says.
pressure.
Yeah, normal pressure. Well, normal pressure, you are referring, Hamida, you are referring to normal pressure hydrocephalus, right?
Yes. Is
Uh,
it not
refer-
that?
Yeah, but I'm asking, why do you suppose that this is atrophy rather than hydrocephalus? Why do you think this could be atrophy? When you look at the brain tissue here, you see the sulci.
Silka says is less, yeah.
Yeah, the sulci and gyri. See the sulci and gyri are getting so prominent. See the prominent sulci and the prominent gyri. See, this is what we call.
Because it's, sorry,
Yeah, sure. Go ahead. No
part
problem.
of the degenerative disease.
Yes, it's because the brain tissue and the parenchyma is degenerating. So that's why you end up having the sulci and gyri becoming very prominent in the brain. And you see clearly that there is loss of brain mass here, or loss of brain tissue here. So this is usually atrophy, and this is what leads to dilatation of the ventricles. But what's there? What's there in the wall of the third ventricle here? What do you think should be here in the wall of the third ventricle, on both sides of the third ventricle? Oh, of the fourth ventricle, I'm so sorry. What's there here? It's usually the basal ganglia, which actually should be like this. See, this is the normal picture. This should be the normal picture. You should see the caudate and the putamen and the internal capsule looks very nice, like very large, huge, like very well looking on both sides of the lateral ventricles in the brain parenchyma here. These are the caudate and the putamen and the internal capsule, which are parts of the basal ganglia. But see here, you see how much this area is atrophic. And I agree that the atrophy here is also involving the whole brain. But what's the disease which is associated with atrophy of the caudate nucleus in the basal ganglia? It's the Huntington disease. Do you remember what Huntington disease is? Anybody remember the genetics of the Huntington disease?
Repetitive of GTT something?
It's CAG. Yeah, CAG. Yes, CAG trinucleotide repeat. It's because of CAG trinucleotide repeat on chromosome number.
Chromosome 4.
Chromosome number
Yeah.
4. Good job. So that's chromosome 4, CAG trinucleotide repeat. And this leads to neurodegeneration, and it usually starts with degeneration of the caudate. It starts with degeneration of the caudate, but it usually involves the whole brain tissue, as you see here. Even the background has neurodegeneration, so it's a kind of neurodegeneration, and the patient usually presents with some kind of aggressive behavior and a change in personality, and he looks like he manifests like an addict, as if he's an addict of something. He's just getting very aggressive. His mood gets really swingy, and he prefers staying by himself. He doesn't like to socialize with people. This is how it starts, and then it progresses to total dementia, and it leads to progressive neurodegeneration and death. That's Huntington disease. And that's caudate atrophy that you see with Huntington. And this is, as you mentioned, is ex vacuo hydrocephalus. It's not true hydrocephalus. This is just dilatation of the ventricle due to atrophy of the surrounding brain tissue. Okay, that's it. So we are done with the non-neoplastic part of the neuropath. So remember, non-neoplastic neuropath is either vascular lesions like AV malformation and hemangioblastomas, or infections. We went over the most common infections that you might see, and also some kind of gross pictures, which are usually traumatic brain injury, and lacunar infarcts and Duret hemorrhage and the central pontine myelinolysis. Okay, so any questions so far? Okay. If not, so let's continue. Now we will go in the neoplastic. First thing, location. We always say that the most important thing in neuropath is the location of the tumor. And I'm sure that any neuropathologist told you the exact same story or the exact same thing. Two people or two pathologists can never function without radiology pictures. The neuropathologist and the bone pathologist. Bone pathologist also is very important for him, the radiology. I know radiology is important for everyone, but for these two specialties or for these two subspecialties, they can never function without radiology because the differential greatly depend on location, where exactly the lesion is. Is it like outside the brain, extraaxial, coming from outside, coming from the dura? Or is it intraparenchymal brain lesion? And if it's intraparenchymal, where exactly is it located? Is it a midline lesion? Is it cerebellar lesion? Is it like a frontal lesion? So is it like a huge lesion with multiple dense and hypodense areas and crossing the midline? This is usually how GBM looks like. So this gives us a huge a benefit of formulating the correct differential diagnosis based on what we see on radiology. So location of the lesion is very important, whether it's supratentorial or infratentorial, whether it's intraparenchymal or extraaxial. Let's start with the extraaxial masses. So extraaxial mass means it's coming from outside. It's coming from outside and pressing on the brain, and it's usually coming from the dura. And it has some kind of dural tail. It arises from the arachnoid layer, usually, of the meninges. What they call this most common brain tumor or most common primary brain tumor. What do they call it? They call it meningioma. Yes, good job. That's meningioma. Meningioma is very important. And you need to clearly identify the meningioma and clearly know how it looks like. Well, meningioma, it has a whole bunch of patterns, I understand. But the most classic form of meningioma is what you see here. My mentor, Dr. Kleinman, always said that this is like syncytial cells. What is the meaning of syncytial cells? Can you appreciate any cell borders here? Anybody can see any cell borders here? Well, nope, I can't see any cell borders. There's no really clear cell borders here. The cells look like syncytial. And it's usually lacy cytoplasm. What lacy cytoplasm means that it looks like a lacy skirt. The cytoplasm is very lacy, lacy cytoplasm, and the nucleus is like kind of have different shapes. And sometimes the nuclei are forming some kind of whorls in which they swirl around, forming like whorls. This is like we call it Horley pattern. And sometimes you have the intranuclear pseudo inclusions. Very important, but it's not very obvious here. But sometimes you see the intranuclear pseudo inclusions. Can anybody remember another tumor in the thyroid where we saw intranuclear pseudo inclusions? Which one?
PTC.
PTC, yeah, papillary thyroid carcinoma. The PTC or papillary thyroid cancer, you see these like classic intranuclear. This is the nucleus here, and you see another circle inside the nucleus, which look like intranuclear inclusions, but it's actually pseudo inclusion. It's called intranuclear pseudo inclusions, and this usually happen because the cytoplasm or the nucleus kind of send some kind of projections inside the cytoplasm. So when you take a section, you will see the nucleus with the finger that it sends in the cytoplasm cut like this, which appear intranuclear, as if there is an inclusion inside the nucleus, but it's not a true inclusion. That's just a pseudo inclusion. Sometimes you see the exact same intranuclear pseudo inclusions in the nuclei of the meningioma. So meningioma, syncytial cells, lacy cytoplasm, intranuclear pseudo inclusions, whorls, might make whorls, and you might see some Samuma bodies, of course. Everybody know, but Samuma bodies is not a classic finding in the meningioma. You might have a lot of meningiomas without any single Samuma body in the field. So here you go, this is diagnosis is meningioma. It's usually dural. It has some kind of dural tail, and it's mostly benign, slowly growing. You need to memorize the key immunohistochemistry that make you identify meningioma. It's EMA, that's a key stain, EMA. And there is a new stain which is very, 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 very famous now. And it's highly specific, highly sensitive. It's the SSTR2A. SSTR is somatostatin receptor 2A. That's SSTR. That's a new stain. It's very, very good, much better than EMA. And the significance of PR stain, if you want to know, it's progesterone receptor. Actually, most of the meningiomas are PR positive. But the thing is, PR expression, the progesterone receptor expression decrease at the grade increase. So I always say that progesterone receptor expression is inversely proportional to the grade of meningioma. Meningioma could be grade 1, could be grade 2, could be grade 3 meningioma. As you progress, the grade increase, the PR expression decrease. And sometimes they use PR immunohistochemistry to confirm that this is a higher grade meningioma because the PR expression is low. So this means that we're dealing with a high grade meningioma. Molecular now is getting very famous in meningiomas. The most common molecular mutation is NF2, but you have a whole bunch of molecular summary or a whole bunch of molecular mutations that might exist in higher or lower grade meningiomas, as you see right here. What I need you to memorize here, what I need you to remember for your boards is the CDK N2A and N2B, which is cyclin-dependent kinase mutation, and the TERT promoter mutation, which happen in grade 3 meningioma. Now, it's believed that in the next version of the WHO book for the brain tumor classification, they would make this TERT promoter mutation and the CDKN2A and N2B, they will make it a must. It's a must for the diagnosis of grade 3. You won't be able to diagnose any grade 3 without seeing one of these mutations. So they will include the molecular test and the criteria for diagnosis of WHO grade 3 meningiomas. Okay, you might see some other mutation where SMARC1 mutation in clear cell meningioma, BAB1 in rhabdoid, KLF4 in secretory, loss of nuclear expression of histone 3. This is a worse prognostic indicator, a worse prognostic marker. You don't really have to bother yourself with all these things. Just focus on the TERT promoter mutation and the CDK N2A and N2B. For the WHO grade 3 meningiomas, okay? That's what I need you to memorize. This algorithm is very important, even for your clinical practice, not only for the boards. I believe for the boards, they would never bother to let you score a meningioma and tell whether it's grade 1 or grade 2 or grade 3. I'm sure about it. But just for the sake of your clinical practice and your daily function as a resident and as an attending, you might get a lot of meningiomas. Well, it's the most common tumor. So you get a lot of meningiomas, and I'm sure you guys get a lot of meningiomas. And the attending will keep asking you questions. How do you know if this is grade 1 or grade 2? How do you approach a case of meningioma? This is very important. So the first thing you look at in any meningioma slide is you look at the cellularity. Cellularity is very rough and subjective between people. So whatever you believe that it might be like, well, hypercellular, or another person will say, no, this is not really hypercellular. It looks to me that it's normal, but some slides and some meningiomas looks clearly overcrowded. That's clearly overcrowded. And that's the cutoff that my mentor always say. If nobody can question that this is hypercellular, so this is when you say this is extreme hypercellularity. So extreme hypercellularity means whoever is blind can just tell you that this is hypercellular. But if we disagree, if there's like disagreement, so this is not extreme hypercellularity. So there's regular hypercellularity, extreme hypercellularity. When you have extreme hypercellularity, start looking carefully for one of these two. Brain invasion, which is brain tissue invaded by islands of meningiomas, brain invasion, and more than 4 mitosis per high power field. And this needs careful microscopic examination by high power, and you look around in all the areas of the slides that was submitted for the meningioma and look around for mitosis. So if it's extremely hypercellular, look for more than 4 mitosis per high power field. If any of these two is a yes, if any of them is a yes, that's more than enough to upgrade the meningioma to WHO grade 2. So this make it automatically go up to a typical meningioma, which is WHO grade 2 meningioma. Okay, if it's a no, is it, well, it's done deal? Is it low grade? No, it's not. You need to look more. Look for the ends. What are the ends? Necrosis, NC ratio, nucleoli, the Ki67. Ki67 is sometimes called it MIB or MIB1, I believe. MIB1 is the same as Ki67. So throw Ki67 and look at the Ki67 index. If the Ki67 index is more than 4, that's a positive finding. If you have prominent nucleoli and then most of the nucleoli are staring at you, that's also one positive finding. If you have a high NC ratio, the nucleus is very huge, occupying most of the cell surface area, that's also a positive finding. If there is necrosis, that's a positive finding. So how many positives you need to upgrade it to an atypical WHO grade 2 meningioma? You need 3 positive out of these 4. If you see only 1 of the 4, 2 out of 4, it's not 3 out of 4, 1 out of 4, 2 out of 4, 0 out of 4. This is not enough to call it grade 2. So it will still be a grade 1 WHO grade 1 low grade meningioma. Okay, so you got it. How to say or how to throw a diagnosis of atypical meningioma? Well, you need either brain invasion or more than 4 mitosis per high power field, or 3 out of 4. 3 out of the 4, which are the ends: necrosis, NC ratio, nucleoli, and the Ki67, which is more than 4%. If 3 positives out of the 4, this upgrades it to WHO grade 2. Well, if I'm standing on the stair of WHO grade 2, I have also to look if it qualifies as WHO grade 3, which is even more aggressive type of meningioma. This needs 2 things. It needs more than 10 mitosis per high power field. So in this case, you'll see more and more and more mitosis, to the point that you see a lot of mitosis in a single high power field, which is greater than 10. Or you see some of these patterns, which are papillary pattern or rhabdoid pattern. I will show you how a rhabdoid meningioma look like or a papillary meningioma look like. It doesn't matter at this time, but just if you see papillary or rhabdoid, look carefully in high power, count the mitosis carefully. If the mitosis is more than 10 per high power field, so you are dealing with a WHO grade 3 even meningioma. If there is no enough mitosis, you're still on WHO grade 2. It's still atypical meningioma, WHO grade 2. What if I have regular hypercellularity from the beginning? Regular hypercellularity means, well, it's nearly impossible that it would be WHO grade 2 or 3. It's usually a low-grade meningioma, WHO grade 1, but make sure you confirm this by excluding any brain invasion. You don't see any brain invasion. I don't see any mitosis. I don't see any of the ends, necrosis, NC ratio, nucleoli, where that's a WHO grade 1. It has a lot of patterns, I understand. And I know that you guys know some of these patterns, like meningothelial type, fibrous meningioma, transitional meningioma, psammomatous meningioma, angiomatous, microcystic, metaplastic, secretory, lymphoplasmacytic. My mentor told me it doesn't matter. It doesn't matter what the pattern is. All these patterns are treated as a WHO grade 1 meningioma, so they are not so aggressive. Once they are removed, they rarely recur. So there is low rate of recurrence. That's what matters for the surgeon. The surgeon is not looking for what subtype of meningioma or what pattern of meningioma it is. He's just looking whether the meningioma is WHO 1, 2, or 3. So it does not matter what the pattern is, all have excellent prognosis and low recurrence rate. There are also two types or two patterns of meningioma that you need to know. It's clear cell meningioma and chordoid meningioma. I will show them to you later, and they qualify automatically as WHO grade 2. But it's believed that this classification will go away in the new WHO classification, and they will just base it on the brain invasion and the mitotic rate and the molecular, rather than saying that this pattern automatically qualifies as WHO grade 2. Or this, like when you see rhabdoid, it's automatically WHO grade 3. No more. I don't believe that this is gonna change very soon. So that's the path algorithm for the meningioma. I hope it helps. If you print this out and put it somewhere, it will help when you approach a case of meningioma. It's gonna be very nice. Yes, Noor. Noor is asking, well, if I see papillary or rhabdoid, but I don't see the 10 mitosis per high power field, now it's not grade 3. No more. It used to be before, but now no more. You have to see the high mitotic rate, you have to see the brain invasion, you have to see the signs of high grade. You cannot rely only on a pattern to throw a diagnosis of grade 3 meningioma. Okay? Any questions until now? So that's it for the meningioma. Make sure you memorize the features of meningioma and the signs of invasion, or the signs that tells you that this is grade 2 or grade 3. Anybody know what immunohistochemistry we use to confirm brain invasion in meningioma?
GFAP?
Yes, good job. So that GFAP, we do GFAP. GFAP highlights the reactive gliosis that happens in the brain tissue due to the invasion by the meningioma. So you will see the islands of meningioma, they are not stained with GFAP, and the surrounding brain tissue stains brightly with GFAP because of the reactive gliosis happening due to brain invasion. Okay, that's a good job. So that's a GFAP. It's a stain to confirm brain invasion, if you want to know. Well, the next is I see malignant glia, glial neoplasm. Anybody know what's the most important feature that tells you that you're dealing with glial neoplasm? Especially on frozen. Especially when you get on frozen section and you want to know, or you want to confirm that this is actually a glial lesion or a glial neoplasm. Well, yes, you do this touch prep. Anybody do this touch prep? You know, this squash.
Yes.
Yeah,
Didn't you see like fibrillary?
Yes, the fibrillary background. The fibrillary background is called the neuropill. You know, it's called the neuropill. So when you get a small piece, a very little piece of the brain, and then you squash it between the slides, between two slides, it's like making a touch prep. And you just stain this and look under the microscope, and you see these stretching fibrils, stretching red fibrils in the background. That's when you start saying, this looks like glial lesion, or just this looks like glial neoplasm. You see a lot of cells and then fibrils in the background, the red fibrils in the background. That's what malignant glia means. So I see malignant glia. Look carefully at the location. See, these are actually the glial neoplasms, and I'm sure that most of you guys know about it. So the key things in the glial neoplasm are whether you are dealing with an astrocytoma or a GBM or a glioblastoma. Astrocytoma, glioblastoma. There are some other glial neoplasm like ependymoma, oligodendroglioma, and some others. But the key thing, the two people that look really potentially the same are the astrocytoma and glioblastoma. And now the differentiation between these two tumors is based on molecular. Well, there are some histological clues that might point towards glioblastoma or GBM or point towards astrocytoma. However, you cannot throw a diagnosis of glioblastoma or astrocytoma except at least when you see the IDH status. What's IDH? IDH is one of the enzymes of the Krebs cycle. I believe it's idocitrate dehydrogenase, which is IDH. So which one is IDH mutant and which one is IDH wild type? Anybody know?
Glioblastoma is IDH wild type, but astrocytoma is mutant.
Yes, so astrocytoma is usually IDH mutant, not all the time, and I will tell you which exceptions are there, but it's usually IDH mutant. You see IDH mutation, and sometimes this IDH mutation is found by IHC, by immunohistochemistry, but GBM is usually IDH wild type. So at least look at the IDH status. Well, if you see that this is IDH wild type, it's highly likely glioblastoma, and it's IDH mutant, it's highly likely astrocytoma. What else points towards glioblastoma? You need to remember these. Not only IDH wild type, being IDH wild type, and also it's TERT promoter mutation, EGFR amplification, and chromosomal deletion. Chromosomal deletion usually involves chromosome 7, I remember, and chromosome 1, I believe. We will come to that later, but just like kind of chromosomal deletions or chromosomal alteration. So there is IDH wild type, TERT promoter mutation, EGFR amplification, and chromosomal alteration. Should it have all these four? No, only one is enough. Imagine, only one is enough. So IDH wild type, this is classic. So you need to say that this is IDH wild type, but plus you need at least one of these to confirm that this is GBM, either TERT promoter mutation, EGFR amplification, or chromosomal alteration, like one loss, I believe 7 gain, chromosome number 7 gain, or chromosome number 1 loss. That's GBM. So astrocytoma, as we mentioned, is an IDH mutant type or IDH mutant tumor, and glioblastoma multiforme is an IDH wild type. And that's why, as mentioned right here, is the IDH is the most important prognostic factor for grade 4 astrocytoma. Because if it's IDH mutant, that's a high grade or grade 4 high grade diffuse astrocytoma. High grade astrocytoma is way much better in prognosis than being IDH wild type, because this will make it as a grade 4 GBM, glioblastoma. And glioblastoma is very fatal. The prognosis is very bad. It might be fatal within less than 1 year. Within less than a year, the patient dies. That's the GBM. So the key prognostic factor here is the IDH status, whether it's IDH wild type or IDH mutant. So see, here are the different grades of astrocytoma. You have grade 1, which is pilocytic astrocytoma. That's have an excellent prognosis. with surgery, radical surgery, everything is fine. And then grade 2 astrocytoma is diffuse astrocytoma. You will see some kind of nuclear atypia histologically, and this usually the patient survive more than 5 years. Grade 3 is called anaplastic astrocytoma, and it has 2 high-grade histological criteria, which are nuclear atypia plus mitosis. So you see high mitosis. This the survival is 2 to 5 years. And then the grade 4 glial neoplasm is either GBM or grade 4 astrocytoma. It's either GBM or a grade 4 astrocytoma. What determines whether it's a grade 4 astrocytoma or a GBM is the IDH status. If it's IDH wild type, it's the wild tumor. I always say wild type is the wild tumor, which is the GBM or glioblastoma multiforme. And if it's an IDH mutant, that's astrocytoma, a little bit much better. But if it's a grade 4 GBM, the survival here is a year or less than a year. And here you have 3 high-grade histological features, which include nuclear atypia and mitosis, plus necrosis or endothelial hyperplasia. Necrosis or endothelial hyperplasia, which is vascular proliferation. Vascular proliferation means the tumor is rapidly dividing. It has a lot of cells to the point that the cells are making some blood vessels to get some blood supply for the growing tumor. And usually the growing tumor is very fast growing to the point that there are areas of necrosis despite the high vascularity and high blood supply that you have. It's never enough. The oxygen here is never enough and the supply is never enough. So areas of the tumor undergoes necrosis. So necrosis with endothelial hyperplasia, vascular proliferation, and you have the nuclear atypia and mitosis. This is the GBM or glioblastoma multiforme. Okay. The grade 2, 3, and 4 glial neoplasm, they call them diffuse gliomas. Diffuse gliomas means that it's at least grade 2. Grade 1 is the pilocytic astrocytoma. All right. Any questions until now? So how about meeting again tomorrow? Since today we entered late, how about meeting again tomorrow? Anybody agree that we meet again tomorrow and finish the second half of the presentation?
Yeah, no
Sure.
problem.
No problem. All right. So we need to finish the second part because I need to finish the neuropath this week. So we finished 30 slides out of the 60. I will share the PowerPoint with you guys on the Telegram group. It's very important that you go over this PowerPoint many times, as many times as you can. Hamida, you won't find
Yes.
you won't find any question outside this PowerPoint, I'm sure. So
Wow.
just go over it many times as you can, hit the images many times. You'll be so good for the neuropath for the exam, okay?
Yes, I was late, but I love the lecture so much.
Thank you very much. Thank you. So we will meet again tomorrow, 9 p.m. Eastern time, and I hope I'm in the correct timing this time. So tomorrow, 9 p.m. Eastern time, I'll see you everyone, okay? And wait for a confirmation from me tomorrow around the afternoon, like early afternoon, I will confirm, okay? Thank you very much, and I will post the recording on the YouTube, and I will share the presentation with everyone. See you tomorrow.
Thank you. See you.
See you. Thank you.
Thank you.